Butler-Smith, and here we are today with another wonderful KBF show interview. We're interviewing Jennie Lowes. She's a registered general nurse and has been working for the NHS for a number of years. So I'm going to hand over to Jennie now, and we're going to find out what she has to tell us about what's been happening in 2020 with the COVID pandemic. So Jennie, first of all, thank you very much for joining me today. I really appreciate it. And what would be really helpful is for you to explain what you do, what your role is, and what you have done in your career, just to give people an idea of who you are.
Okay, so thanks, Leah. Thanks, nice to talk to you as well. I first started my career into care when I was 16, really, and I started working as a healthcare assistant in a nursing home, and I earned £2.05 an hour, and I learned a lot during that time. I was young, but I learned a lot during that time, and I always wanted to be a nurse, so I did my nurse training, and I finished in 1999. Not long after I finished, I went and worked within surgery, gastrointestinal surgery and vascular surgery, and then I moved into high dependency nursing and then into intensive care nursing. And before I left the NHS, I was working in a big general hospital as a critical care outreach matron, which was to bridge the gaps between the critical care and the wards, and also ensure that patients that were deteriorating and acutely unwell, that we managed to get them to the intensive care unit in time to get the right treatment. So I worked a long time within critical care. I left then in 2011. I went on maternity leave, and then I actually moved to Portugal and started working as a nurse recruiter for a nurse educator for foreign nurses who wanted to go and work in the NHS. So I've got a lot of friends that still work within the system that I trained and I worked with, and I also have a lot of nurses that I placed in the system. The company that I worked for placed thousands of nurses within the NHS from Europe and India and the Philippines over the last few years. So I have a reasonable perspective from what people have been telling me, and also from previous experience, because I worked the swine flu year. The pandemic's down as a swine flu year, that it finished in August 2009. But actually, if you speak to members of staff, the worst winter was between 2010 and 2011. And we had a significant number of patients die, young patients die that year. It very much affected the young. We even had pregnant women that died and that had to deliver their babies early. We had a lot of deaths in children as well. Not to the level that we've had with COVID, but in the general population, but significantly impacted the younger more than the older, like we have with COVID-19. It seems to affect more the over 70s, whereas swine flu, that winter particularly hit the young and young adults without any previous medical history as well. So I don't know if you want me to talk a little bit about that, but that winter was horrendous, and we had patients that were ventilated outside of the intensive care unit, which is never a great idea. You need specialist intensive care nurses to look after ventilated intensive care patients. And we had patients that needed to go to ECMO, which is where they take the blood out of the body and they oxygenate it and put it back into the body to give the lungs a rest. And we had patients, lots of patients that would have benefited from ECMO that couldn't get beds because the beds were full. So it was a significant impact that year, even though the figures look like it was a much less serious illness in terms of numbers, actual overall numbers. We didn't routinely test everybody then, and we don't know if the true numbers were true in 2010 either. So when I started to look at the COVID-19 when it was exploding in Wuhan, and I started to look at the case fatality rate, and I started to look at the medical journals, and it was saying that 20% of patients needed hospitalising, 5% of those needed critical care. It doesn't take a rocket scientist to work out that if it ended up going the same way as it did in China, that there would be a massive strain on the NHS, and in particular in critical care. And so just to give viewers a bit of an idea about critical care, the hospital I used to work in had a 16-bedded unit, which was, usually it flexed between ICU and HDU, depending on what the dependency of the patients were. But the critical care guidelines say that one nurse should look after one ventilated ICU patient. And I've heard that during this period, there were at times one nurse looking after 4 intensive care patients, and that in some areas, and that really shouldn't have happened, because they were supposed to be mobilising lots of people to go and make sure that they cared for those patients. But I mean, I know I volunteered to come back and to work within critical care because I have critical care skills, and I know other people that did and never got contacted.
Yeah.
And I know it said that I think there's something like 50,000 nurses in the UK that are registered to work that aren't working, and it doesn't seem like many of those got a call either. Plus, they obviously staffed the Nightingale hospitals, which didn't get that many people through. But in the meantime, during the peak, which looks like, if you look at the figures, especially in intensive care, that lasted about six weeks, more or less, and then the numbers started to come down. It shouldn't have been like that. The patients that were in intensive care should not have been nursed at that ratio, and it will no doubt have impacted on mortality rate overall. And even the PPE issues, the PPE issues with just even putting PPE on for every patient that you go to see takes up a lot more time. It puts a lot more stress on the health service, and it means that nursing care, you're not delivering the correct level of nursing care that you can. So I think a lot of nurses worked extremely hard during this period. I think in the peak and before the peak, it would have been chaos, knowing, how the health service kind of runs. It would have been chaos, and there would have been a lot of confusion. And there wasn't much guidance really coming down, and it was getting confused and changed all the time as well. So the nurses on the front line and the doctors on the front line were trying to firefight really at the beginning, trying to understand what was going on. But it looks like, admission rate has dropped right down now. Mortality rate has dropped right down. And at the beginning, they were recording about 50% mortality rate in ICU. So patients were being ventilated, they had a 50% mortality, which is higher than average. Patients with acute respiratory distress syndrome, secondary to sepsis or something, they have about a 25-30% mortality. So this was a lot more.
Mm. And I mean, it's interesting because I'd interviewed a lawyer previously, Claire, and she was talking about how there was nothing done, given that we were supposed to be protecting the elderly. That was one of the big slogans, and still is. That there was nothing done by government or by the chiefs above to support the care home staff with all of those nurses who had nothing else to do, who were, we were sort of seeing nurses talking about the fact that they were surprised they hadn't been called in. Some were still being made redundant. I remember seeing people talking about that and saying, I can't believe I'm still being made redundant, when actually there's this desperate need for us all to kind of band together and support. And as you said, with so many wards empty, obviously the TikTok videos is a big thing that has been discussed for different reasons. Part of me actually thought at the time maybe the nurses wanted us to know that they weren't as busy as what we were being given to believe in the media. But clearly from what you're saying, the ICUs really were very much overwhelmed, but it was a lack of personnel and not necessarily a lack of equipment or resources, and they could have funneled and should have funneled staff in to support. So it doesn't make any sense, does it? I mean, have you been able to work out has anybody offered, the friends that you have they said why?
I think obviously at the beginning, as it was starting to evolve more and more and there was more cases, a lot of nurses don't have that much time to sit and read the newspapers and watch the news and go through and do their own research. They work 13-hour shifts, they work really hard, they come in, they go home. And, at the beginning and leading up to the peak, the hospitals, I was looking today at the percentage occupancy rate. You can go on the NHS England and look at the percentage occupancy rate, and it's quite interesting actually. So from January to March, there were 129,992 hospital beds, general and acute hospital beds in England, not in the UK. And there were how many? 118,451 were occupied. So that's quite a big number. Like it was almost. Some hospitals were already at just 60%. Some hospitals were up to 96% already. So this is leading up to the peak. So they're already all full. And then you only need to get a very small increase in patients going to hospital to put pressure on those hospitals that are already at occupancy. And one of the things that's interesting, that would be interesting to understand, is how many inter-hospital intensive care transfers they had to do, because that would show you which intensive care units were full and why they had to transfer those patients out. Because, you know, if a unit is full and you've got a patient that needs to come in, you either transfer the wellest patient out or you transfer that sick patient out to another hospital. The best scenario is you transfer the wellest patient in ICU, because transfer can be quite critical, obviously. So it was anything from 88 to 90 something percent. But from April to June, so during the peak, there was 76,340 beds occupied. So that's an average of 62%. But some of them was as low as 22%, up to 90%. So some hospitals were running at normal capacity, they were full, and they probably wouldn't notice that much of difference in terms of workload. But other hospitals dramatically reduced those workload. And, you know, you said that you have people that you've spoken to that weren't doing anything, that were asking to be redeployed and things like that. That's something that's come back from some of my friends as well that work in the critical acute areas, like pre-assessment, for example, so for surgery. She asked to be redeployed, one of my friends, because she's got intensive care skills, and she kept asking every day. Apparently she was asking to go, and they said that they didn't need her and that she should stay where she was, and she was doing e-learning for 6 weeks. And, you know, if there'd have been any coordination, those nurses should have been redeployed to nursing homes. However, nursing homes on the main are privately owned, so they're not owned by the NHS. There are not many nursing homes that are run and owned by the NHS. Most of them are private. And, you know, when you look at nursing homes, when I worked in a nursing home, I went back as a trained nurse, and I had to leave, actually, because I couldn't work under those circumstances. I used to go in and I'd be in charge of 30 patients, and we'd have one box of gloves that we were allowed to use for the whole shift. I mean, this was 20-something years ago. And we used to have to wash them out. I used to go and buy my own gloves and take them to work and give them to people. And that's in the private sector. And, you know, the private sector isn't as well controlled as such as the public sector, because it's a bit more, although it's still looked after by the Care Quality Commission, you still have some degree of standards. It's not quite the same. So, and also in those nursing homes, they run at very low nursing levels. So you might only have one nurse for 30 patients. You have carers, of course, but one trained nurse. And if that trained nurse is already under pressure, and then you've got a bit of an outbreak of COVID in the home, it's going to put so much pressure. So no wonder the death rate has been so high in nursing homes. Not only that, obviously, in nursing homes, they're elderly and often have a lot of comorbidities, and they don't get outside much and get much vitamin D. Nutrition-wise is probably not always the best. So those are our most vulnerable people in really.
Yeah, and of course our reports show that the elderly hadn't even been allowed to go out of the home, and they're still not allowed to go out of many homes. They're not free people at the moment. They haven't got any choice, and they're not getting any of the normal sorts of professionals that would come in just for toenails and things like that. The care home workers are not allowed to touch, and the hearing aids, glasses, all of those sorts of things, they're just not being looked after. And this is 6 months of not being looked after. Now, you mentioned the CQC just then, and also something which you might find quite interesting, that the CQC had not been made aware that no doctor had been going into a care home. There was no doctor present when a diagnosis of COVID was made, and if that patient was then put on to end of life, it wasn't with the usual protocols of having that doctor making that diagnosis officially. It could have just been a telephone call. And I mean, that's just horrific. And we were supposed to be protecting the elderly, and we clearly haven't been. So what else have you got, have you heard from the UK, and what else have you observed? Because I understand from, you know, we had a chat yesterday, and you've been studying all of the statistics, you've been looking at those. So is there anything else that you're sort of hearing that's made you a bit more concerned about what's going on?
Well, I have a lot of things that I'm concerned about what's going on. And one of my main concerns is that the NHS is being destroyed from the inside out now. And, you know, the whole thing of the COVID and the lockdown was to protect the NHS. and now they're months behind now in elective surgery, in diagnosis, in other therapies. They're going to be way behind, and it's going to take them a long time to catch up from this. I mean, Matt Hancock said the other day it'll be caught up in months. So one of the things I know that how they're trying to catch up is that some of the operations, the elective operations, are going to the private sector. So they're already siphoning off some of that to the private sector. The other thing that really concerns me, having been a nurse recruiter for a lot of years, is there are 44,000 nurse vacancies in the UK as it stands. And they only train, I think it's something like 15,000 nurses a year. So every year we're at a deficit, and it's growing, and it's growing. And the NHS has relied a lot on European nurses, and then also non-European nurses as well. And it's been very difficult to recruit European nurses recently because the Nursing Council changed the level of language that you need. So nursing trusts have been looking more and more overseas to Philippines, which we've recruited a lot from the Philippines in the past, India, the Caribbean, and some other areas as well. And all of that stopped. So all of the interviews, I mean, at our peak, when we were at our busiest, we had interviews running all the time, and we were having nurses travelling all the time, sometimes 50 nurses a month. This was a few years ago, but 50 nurses a month were travelling. And that's just stopped. So there's going to be a big deficit in nurse numbers as well at the end of this, and that's going to be very difficult to catch up. And one of the biggest factors in terms of in-hospital mortality is staffing, staffing levels. If you don't have enough staff, mortality goes up, and that's not just me saying that. You go to the medical journals and everything says that. And it's, you know, we don't already have good enough staffing levels to produce safe nursing care, I don't think. And that was from 2011 when I was working. There were, every single day, there wasn't enough staff to produce the level of care that should be being produced in the NHS. And I will say that there are amazing nurses that work in the UK, and amazing care assistants and amazing doctors, and most of them do so because they care. But they have been ground down so much, and they've just been ground down even more. I wouldn't be surprised if lots of nurses leave the NHS in droves, actually, after this. You know, they've had a high level of stress. There's lots of people talking about post-traumatic stress. They had to just deal with it. And, you know, I've seen there is absolutely no excuse for negligence and for neglect and for elderly abuse or anything like that. And we should be absolutely safeguarding our vulnerable adults to the maximum. But staffing definitely does have a big impact on that, on the ability to be able to do that. A few of the things that I've heard from the community are that it was impossible for the community nurses to get diagnostic tests done on their patients, x-rays, ultrasounds, bloods, because there was nowhere for them to go. So there's been a massive backlog with that too. And then the other thing I heard with the nursing homes like you have is that doctors weren't even going in to the nursing homes, they were diagnosing through the window. And that is so bad, because that doctor can't possibly know whether that patient has COVID without examining them, because the symptoms, there's so many symptoms, they can match with lots of other diseases. And, you know, imagine if you have an elderly patient that's just suffering from very bad constipation and they need an enema. And the doctor decides, because they're breathing really fast and they're not eating and they've, you know, deteriorated a little bit, that it's COVID. And they sign that it's COVID and they put them end of life. And really all they needed was an enema or something like that. That's tragic. I mean, that is pure neglect, really. And yeah. I hope that nurses are reporting this. And when I worked on the wards, whenever there was something that wasn't right, I used to always say to the staff, write an incident report, write an incident report. We used to have to do it on paper, and then it became electronic. And yes, it took time. The nurses were like, we're too busy, we've got this to do, we've got that to do. No, sit down and write an incident report, because if you don't, nothing gets done, because they don't collect the data. It's only when they have enough data and enough of a trend that they think, now we need to investigate what's going on here. And they did that with medication errors years ago. I'll say this very quickly, but years ago they worked out that a lot of the medication errors were happening around the time of visiting hours. So the reason is the nurse is there doing a drug round and a relative taps you on the shoulder to ask you about how their mother is or whatever. And you could be disturbed 15 times during that drug round while you're giving out very important drugs. So the trust that I worked at worked this out, and they started to put tabards on nurses that said "do not disturb" on the back, and the number of medication errors during that period of time bottomed out.
Yeah.
So, but they only knew that because people were recording data. So I hope that all the nursing homes are recording incidences, and I hope that all the nurses in hospitals are as well, because it's our duty to do that. We really should be doing that and understanding what's really going on. Because you can have lots of different people talking about lots of different things, but if it's not recorded anywhere in black and white and it's being, shown to somebody in an official capacity, it won't get dealt with. Just won't, it'll just disappear, and it'll, nothing more will be said about it. So I hope that they are. I don't know if they are, because probably the ones that need to write them are the ones that have been so busy, they've been nursing 4 patients to one ICU nurse, and those ones will probably think after the end of a 14-hour shift, I haven't got the strength to sit down and write this incident report,
Yeah.
Other things I've heard from the hospitals were that they did redeploy people, but there were obviously a lot of services that weren't being used. And you can't just train an ICU nurse like that. It takes 6 months to train an ICU nurse. You can be an A&E nurse, for example, and you go to intensive care, and it's 6 months to starting from scratch again. You feel like a student again. And, it takes a lot for a nurse to look after an intensive care patient. It's very technical, and it's very skilled. So you can't just redeploy all those people into intensive care. But hearing about what happened in the community and things like that, maybe those nurses could have been redeployed if there was a system in place to help out in the community, because, I would hate to have been in a nursing home now. And the other thing that I heard was, I have a friend that's a community nurse, and she said to me that nursing homes weren't even wanting district nurses to go in because they were afraid of them spreading the infection round. So they were stopping district nurses going in to do dressings and things like that. And they're the experts of that kind of thing. So if you have a very complex leg ulcer dressing, for example, district nurses are excellent at dealing with that because they deal with that all the time. And she was saying to me that they didn't want us to go in. So what they were having to do was they were taking photos and sending it to them. And then they were advising on what to do. But, it's all well and good, this technology, but when you're looking at a leg ulcer, you want to smell it. You want to, it sounds just, but you want to be able to swab it if you think that there's something wrong with it. You can't do that over, telemedicine. It's not ideal. So I'm not surprised that patients have died in the community in massive numbers.
Yeah.
And also, even in the hospitals, the pressure on the staff and just putting PPE on all the time, which interestingly, I was reading today that they only need to wear a surgical mask, just a normal surgical mask, and an apron and gloves if they're dealing with a COVID patient. Only if they're suctioning, doing aerosol generating procedures, that they need to wear the N95 mask.
That's interesting, as given that we're all told, we're all supposed to be wearing them, and also now children are being forced to wear them in some of the schools, which is, I don't know if you know this, the government will not, or YouGov, which is on the organisation that's supposed to confirm for the Us for Them campaign, they're trying to support children's normality, returning to school as they would do normally, and they cannot get a response. And Simon Dolan's been trying really hard to get the YouGov to say what the poll had said, because we saw a lot of polls going around. Good Morning did one, and one of the newspapers did one, and some people were just doing them on their social media polls. And they were always very, very high refusals, very, very high no. And in fact, there was this very peculiar thing that happened one day where, luckily, people had been screenshotting, and they took screenshots of this poll that just did not change. It sort of reached this 76% no point, and then didn't shift by 1% either way, and then it remained frozen. And there was another that literally it almost flipped. So where it was, again, very, very high no's, by the next day, all of a sudden it had completely flipped over. And equally, that's just not the consensus of opinion that was really going on. And there was one, I think, that they took it down. because it was also very, very high note. So at the moment, the government are prepared to say, Professor Chris Whitty has been saying there is no danger to children, there's no risk to children, and they won't confirm what their policy is. So it's down to the teachers, it's down to the heads, and that is just not good enough to give that kind of advice. So what would you suggest in terms of just understanding? Because if inside a hospital, if they're actually treating the patients and they're not wearing any kind of special masks, then that would suggest that they don't have that level of concern over breathing in each other's air. And so why are we making children? And what are the harms that can come to children if they're expected to wear them for any period of time?
I think the whole mask debate thing is driven by one side saying it's only a mask, wear the mask, do as you're told, it's for the greater good, wear a mask. You know, people are dying, are you stupid? Wear a mask. And then there's the other more sensible side that's saying, well, hang on a moment, let's rewind a little bit. And if we're talking about kids, let's go back to H1N1, which was declared a pandemic. There were 60 million cases, I think, in the US. It was declared a pandemic. Not as many people died in terms of case fatality rate, but it was still classed as a pandemic. And like I said earlier, children were more affected by the swine flu outbreak than seemingly affected by COVID. I haven't read any studies that have said that children are a driver for the pandemic, as in they spread. There are a tiny percentage of mortality, like less than 1% of children that have died, even less than that. And all of those children had a significant comorbidity. So it might have been a child that already had a tracheostomy for a reason, or someone that, you know, there are lots of different reasons that a child might be sick. There are lots of sick children around. So all of the children that died already had a pre-existing condition. The other thing was at the beginning of the pandemic, when they were, and at the peak, nobody was walking around in masks. And they were actually saying, the World Health Organization, the CDC and the government in the UK were all saying the same things. Masks make you touch your face more. Nothing less than an N95 mask will do, which needs to be fit tested, and they're single use that you then throw away once you've used. And there was other things about masks that they were saying that, you know, wasn't needed. And then all of a sudden, it, like we say, it just flipped, and it was like, okay, in 2 weeks' time, we're going to have to start wearing masks. And that was one of the first alarm bells that ran off for me about masks. It was like, hang on a minute, why are you saying in 2 weeks' time? Like, if it's needed, it's needed now. And if it's needed all the time, and not when we can walk into a cafe and take it off and put it on the table, and then we need to go to the toilet, so we put it on again, and then we put it down again when we come back and we've touched it 100 times. And it's madness, you know. The surgical masks, they say offer some protection, and they've been showing these sneeze videos. Have you seen those? Yeah. Where they sneeze with one on and they show that it spreads. But the virus particle is so small, so small, that that's not going to protect you. If someone coughed in your face with COVID-19 and you've just got a normal surgical mask on, it's not going to protect you from COVID at all. And the way the media have pushed this whole, you know, you're doing a service, it's like a patriotic thing to do, don't question it, you know, don't question the science behind it. And I watched a few days ago, it's been uncovered recently, was Fauci talking from America, from the CDC, was talking about how asymptomatic spread is not a driver for disease. So if you are positive, but you've got no symptoms at all, like you just feel completely normal, you are not the driver of disease. The driver of disease is a heavily infected viral load within a closed environment, so a hospital, within your house with other people that are, you know, where do you normally pick things up from? It's usually from the kids or from, you know, isn't it? It's from close contact. Yeah. It's not from picking up a banana in Lidl that someone else might have also touched, that also had. So the whole media thing made this fear of, like, everything that you see around you is infected with COVID-19. And you can see that mindset in some people, you know. I've seen people gloved with double masks. I've seen someone with a mask taped to their face. Right? That thing makes no sense. So it certainly makes no sense to me for schools.
No.
And also, I have some experience of the mask thing with my own child, because, I work from home and I've got 2 children. I had to homeschool 2 children from the beginning of March because we shut down earlier. And one of them's 9 and he's not that savvy with emails and with Skype and all of that stuff. So I had to supervise them a lot. So my ability to work dropped quite significantly because of homeschooling. So when everything seemed to slow down, I decided to put him into a holiday club for a few weeks. And because he's less than 12, I didn't think that he'd need to wear a mask, but I was told to send him one just in case. And after a few days, I realised that he'd been wearing it inside and outside when they were playing outside. And I live in Portugal, it was 80-something degrees and, sunny. And I asked them, I said, why is he wearing a mask? And they said to me, it's because the younger children don't understand and the older children, and some have to wear and some don't have to wear. So we're being inclusive and we're making them all wear.
Oh, wow.
Within 2 weeks, I had to take him out for a week because he had a stinking green, snotty cold. It wasn't COVID. It was just a normal summer cold, which was probably a type of coronavirus, probably because most of them are, or a rhinovirus. And I had to take him out and I didn't send him back in the end because I didn't want to see him running around in a mask. And, they take them off, they put them on, they take them off, they put them on. Kids wrap them around their face, they stuck them in their pocket. Trying to get kids in masks, especially under, 10, it's going to surely do more harm than good and be more of a transmission, factor than anything else. And I'd just like to say to parents is, also, what's happened is over the years is that both parents tend to work. So parents kind of rely on school a little bit for childcare as well. And, grandparents are spread around and everything. Is don't send your kid to school when they're sick. If your kid has a fever or your kid has a stinking really bad throat, or don't send them to school, or gastroenteritis or something like that. But unfortunately, what parents do is they send their kids to school when they're sick. So what I fear about the school thing is that kids will go back to school as they do in September. Weather's going to start getting colder. Kids are going to pick up colds and, usual stuff. And then they're just going to shut schools down again.
Yeah.
There isn't what we do. It's kind of like an unknown. We don't really know what's going to happen when the kids go back to school. In terms of other illnesses, they've not been mixing that much. Mixing with other people helps your immune system because you're constantly, boosting your immune system if you're with other people. And kids have been segregated for a long time, and then we're going to put them back in with loads of other kids with this crazy mask stuff. And
and stress, and that's my area is stress and mental health. And I'm just so acutely aware, especially from the parents who are talking about this, that their children are very, very anxious and very, very stressed and worried about what school's going to be like and worried about having to wear a mask all the time. And some of them feel quite claustrophobic with it. But it's even just because they've had so many things have changed in their lives. And human beings don't like change terribly much. Yeah. We resist it as much as possible. And that's why, all this flip-flopping that the government have done with their rules and regulations has been part of what adults have experienced as stress. So stress on the immune system, as you would explain to people, is a big, big factor. And what are the things that you would recommend parents do to protect their children so that when they do go to, because of course, your immune system will still work. So how can they support that when they're in school to prevent sickness getting too bad? They're going to get sick, we know that, but how, just to stop it from being significant?
Well, I think with anybody, like with adults or children, one of the most important things is diet and it's nutrition, and it's also rest and about stress and like you say. And this whole period has obviously created a lot of stress for people and a lot of fear. And they're low vibrational energies. They cause internal stress and they contribute to illness and they decrease your immune system. But I think just with kids is making sure they eat well as possible in terms of they're getting lots of fresh fruit and vegetables, they're getting a variety diet, that you're not, filling them full of sugar all the time. Watch their sugar intake because sugar is inflammatory, causes oxidative stress as well, and can lead on to further problems with the immune system. And just try and keep to as much of a natural diet as you possibly can, natural plant-based whole grain diet as you possibly can. And also encouragement of being outside. So even in the winter, get your kids outside in the daylight when it's sunny. In the winter, you can go out obviously at lunchtime the sun's not so strong. But I would definitely recommend, because vitamin D for sure has a big impact in terms of mortality and in terms of severity of disease. And they already know this from previous studies in respiratory failure and respiratory infections, that vitamin D deficiency or low levels of vitamin D are a contributing factor to severity and to mortality. So with kids, it's the same thing. You know, when I was a kid, we used to play outside a lot more than we do now. But so as parents, I'd be encouraging them to do that, wash their hands. And as a parent, trying not to instill any fear into your child, because I think that, you know, the risks are really low to children. And I understand, I've got 2 children, and I was actually, when they shut the school down, I must say I was relieved for a little while, because, you know, the initial reports looked like the mortality rate was sometimes up to 25%, and that is horrifying. You know, you can, if you're looking at a mortality rate of 25%, but it's not that anymore, because there's more cases, the mortality rate proportionately is much less. So there doesn't need to be any fear with kids. And I think trying to, you know, don't go near that child and don't do that and don't do this, and that will create more fear in them. It just relax, you know, if they want to wear a mask and they feel more comfortable in a mask or whatever, or they don't, they should be able to have a choice. And everybody should be able to have a choice, I think. But yeah, as a parent, I think just trying not to push on your anxieties onto the child. Children are robust. They get sick all the time and they get well fast. They deal with things a lot better than we do. The other thing is, you know, there hasn't been any confirmation on this, but at the beginning in France, they said that there was an increased rate of mortality with the use of ibuprofen, and there was some conversations about whether you should use ibuprofen or non-steroidals. So only use like paracetamol if you need to, if the temperature's gone really high. You know, keep well hydrated, good diet, be outside, and just try and get the kids switched off as much as possible from what's going on, because inform them and make sure they're informed, but to just be kids. Yeah. I think kids just really, really need to be kids.
Yeah.
And be with...
And be told that it's not a risk to them.
I can't imagine how it would... Sorry, I can't imagine how it would be for a teacher either. If she's got a class, you know, trying to maintain and mandate the mask and the social distancing and all that. I mean, it's going to be a nightmare.
I actually have some really deep concerns about teachers returning to school, managing the. I mean, I think the older children, because they're being made to wear masks, that's going to mean they don't have to do some of the other measures. But the younger children, it's a reliance on these other measures. So they've removed every piece of artwork that children see. That's how school feels more comfortable, more fun. And they've removed all of that. They're not allowed to go into the library, touch the toys. You know, it's disinfect this and disinfect that. Instead of the children being on round, or as they were, you know, all looking in on each other, now they're all facing forward. So there's a lot of things that they've changed, even for the really young children. And for teachers to try and manage these bubbles that they're supposed to be keeping them all in, and that's how they're wanting to manage it in those younger children. I just think I really am very, very deeply concerned about the teachers' stress levels, and also, as you said, the uncertainty, because if somebody does get sick, and I'm not sure what they're going to do about testing, because that worries me enormously as well. I don't like the idea of, I would hate the idea of any of my children having something shoved up their nose and shoved down their throat. And actually, I have a friend whose client is a lab worker, and they've actually been doing a lot of the tests, and they laugh at the idea of shoving this thing all the way up someone's nose and right down their throat. They say you don't normally ever do things like that. It's a swab on the inside of the mouth, swab it round the nostrils, and that's kind of as far as you go. So what on earth are they doing? And they can't understand it. And I thought, well, if they're lab workers, they think it's strange, then we should be concerned. Why are they doing that? So what do you think about the PCR test? That's actually an interesting question, because that's been a big debate, hasn't it?
Yeah, well, interesting you were saying about the swabs. So whenever, we used to take a lot of nose and throat swabs and things like that. For one, you'd always take a nose and throat swab separately. You wouldn't take the throat first and then the nose. And that's what I've been told by people that have had tests that have been done. And then it goes right back. And usually you just put the tip into the top of the nasopharynx, and that's enough. So with the testing, you know, asymptomatic people, you're going to have to try really hard to get a positive test from an asymptomatic person. A very productive symptomatic person, you would only need to get a tiny swab, and there would be enough viral load to get a screen, a positive result. The PCR testing, I've seen a lot of different things. I've seen reports of some tests being contaminated in the United States and Spain, I think it was. There are lots of reports of false positives and false negatives, so how we can get any idea of accurate numbers is very difficult. And then, there are a lot of people saying that the PCR test only tests for the genetic material of any type of kind of corona-type virus, so we don't know if it's very specific for COVID-19, but I don't know enough about the PCR testing to say that that's completely right. But I know on the CDC website, it does say that it just tests for a type of corona. It doesn't say specifically COVID-19. And, the press have not helped with this issue as well of trying to understand, because they've use different terms for different things. Sometimes they say SARS-CoV-2, sometimes they say COVID-19, sometimes it's coronavirus. So, when they're talking about someone has tested positive for coronavirus, I don't know if they mean a coronavirus or they mean specifically COVID-19. So that's why it's very difficult to try and interpret the numbers and get any idea as to exactly what is happening. But with testing, I think this mass testing thing is just stupid in a way, because if you're testing, I saw today that on average, 2.8% of worldwide tests have been positive. So that means that 96.2? Yeah, 96.2 of other people have either had another respiratory or some kind of illness that has similar symptoms, or they've been completely asymptomatic. So if only 2.8% of tests are positive, that means that the rest are either walking around with other respiratory illnesses normally, because I wouldn't go and get a test unless I was really ill. Unless I felt worse than I'd ever felt before, I wouldn't get tested, because I think my body can deal with this. In fact, I think we possibly had it in December. I don't know if we did or not, because we weren't testing and we didn't get tested. But it was a bad flu for two or 3 days. That's how it kind of lasted. And it was a strange flu, high temperatures and really itchy skin, really irritable. But I don't know if we had it or not. And the PCR testing, there's lots of different types. Not all of them have been properly verified and tested and compared with other samples and things like that. So I don't know exactly the PCR testing, but I do know that it's probably not 100% accurate in all cases. So, there definitely needs to be something as to whether that is the main diagnostic tool. And in Wuhan, they started to use CT scan as a diagnostic tool in the end, that people with ground glass opacities in the lungs, they were put as a positive test, even if they'd had negative PCR testing. So, there are lots of inconsistencies worldwide about the way people have been testing. And whether or not, I'm not 100% sure, but whether or not the PCR testing is COVID specific, or whether all of the testing that they're using is COVID specific or not, I'm not 100% sure on that.
What's really worrying about it all is that they're using, because the Lancet actually published their comments on it, and as far as they're concerned, you do need to have symptoms, because as you've just explained, if you're symptomatic, you've got enough of the viral load for them to not have to spin the machine very many times. And if they have to keep spinning and keep spinning and keep spinning it to try and get any kind of information out of it to class that as a positive case, that just constantly reminds us that actually that person's not infectious. So they can't pass anything on to anyone, even if they come back with a positive case, because there's not enough of the virus in their body to go anywhere, to infect anyone else. So the concern is that the test itself doesn't seem to be really beneficial in any way, so it's meaningless. But they're using that as the driver for the removal of health, access to health. It's a whole bunch of human rights, and that's what I get people shouting at me about. Like, why are you complaining that human rights just because of a mask? No, it's a big picture thing. The mask is just a sign of acquiescence, as far as I'm concerned. It's a way, as you've said, if it was that important, if the scientific the new science that they'd suddenly come up with was that serious, they'd be like, today, now, come on, everyone get your masks on, it's really worrying. But no, they didn't. And then they didn't, you don't have to wear it here and you do have to wear it there. So it's all of these other inconsistencies. And it just seems to be much more about making sure that the people are doing what they're told. And a lot of people's concern is that that's a preconditioning so that when the vaccines, which they've spent an enormous amount of money on, without asking, do you want us to rush through this experimental vaccine so that you can all have it and then you can go back to normal, when actually we should be back at normal now and should have been back at normal for some time. So, you know, that's why I think the concerns over the test is really, really significant. And I am surprised that given that the Lancet's original, as it seemed, fraudulent paper that was published about the hydroxychloroquine was bandied around until it was shown to be fraudulent. But so in other words, you know, when it suits, the Lancet's a very, very important publication and we're going to talk about what they've said. That's a fraudulent, let's chuck that in the bin. But now there's this other one which actually disagrees with this driver that they're using to you know, threaten to lock everybody back in their houses and remove more human rights. That actually it's not, none of it makes any sense at all, other than there's something else going on. And that's why I think a lot of people think it's about programming, conditioning people to just accept the vaccine when it's produced. So do you know anything about that? Have you actually researched it? Because obviously anybody who's never been concerned about vaccines, you know, go to the doctors, get my vaccine.
Well, my background as well is also a little bit in medical ethics. I did a master's in medical ethics and law, and I sat on a research ethics committee for quite a few years as an expert member, but I was the only nurse on the committee. And I have a real passion for ethics, and what I always tried to teach through my teaching as a nurse, but also how I used to practice, was that autonomy is the number one principle of medical ethics that we should respect. And if we don't respect individuals' autonomy, we are completely destroying any sense of being human, really. It's like we have the ability as humans to process information and make decisions about ourselves, and we are the people that are most, you know, used to making decisions about our own body. And I think bodily autonomy and patient autonomy is absolutely essential to maintain, and that's what's worried me so much about this. Like, this is what is happening, and like you said, to hand that over, to willingly hand that over on tests and cases and deaths that we don't know for sure are the real numbers, and you know, it's highly likely those numbers are overinflated. The CDC have just said that there are 6% of cases died of COVID, just COVID, nothing else. Only 6% of those cases. So if that's the case, and we're being asked to do all these different things and comply and you know, accept a vaccine with open arms, as a forced vaccine with open arms. No, that's completely wrong. And we need to be nailing down about ethics now. We should have been doing it months ago. And you know, we are not in any way protecting patients' autonomy at the moment because we are not getting the information. So when we're talking about autonomy, most of the time we're talking about consent, because autonomy is the main factor to be able to consent for something. But to have autonomy, you need to, and to consent, you need to have capacity. So you need to be able to understand the information, process the information, understand what that information means for you, and make a decision. So you need information. You need to be free from coercion. Now, I would argue that we are not in any way free from coercion, because the media have rammed this down everybody's throats, and they've created this, you know, fear. It's just fear everywhere, and judgment. I think there's an awful lot of judgment going on at the moment. That person's not wearing a mask, or that person is, or, you know, there's a lot of judgment going on. And essentially, it's our choice what we want to do, or it should be. It shouldn't be the government's choice. I mean, you know, as a good citizen, if it meant that it really was for the greater good, and it really was, and it wasn't going to impact on like individual autonomy that much, I probably wouldn't have that much, you know, problem in doing it. But if you're asking people to make decisions on bad information, with coercion, with, you know, all those different things, you completely invalidate any forms of consent. And that is our absolute principle, guiding principle of medical ethics. After that, it should be in the patient's best interest. So after we've talked about autonomy, we talk about beneficence, and that means in the patient's best interest. And every medical decision that's made, if the patient can't exercise their own autonomy, should be in the patient's best interest. Who decides that usually is the medical team in collaboration with the patient and the family. And that is interesting when we talk about do not resuscitate orders, actually, or do not attempt resuscitation. And then we have non-maleficence, which is do no harm. And then we have justice. And when you look at all those 4 principles of medical ethics, we are not, the government are not supporting any of those at the moment in any way, because we haven't got true, transparent figures. And we don't know exactly what has been going on. What we're getting at the moment is lots of stories from different places. Every patient that's admitted to hospital has certain information recorded on the system. And especially in intensive care, they have a very good data collection service in intensive care. It's called ICNARC, and they record all things. And there are certain things that the government has stopped recording data on. I was really shocked when I found this I only found it a few days ago. I just happened to stumble across it. And the PDF was from July. And it said that they're stopping to collect information on emergency operations, cancellations and ICU capacity. So you might have a patient that needs an emergency operation, but you don't have an intensive care bed, so you delay the operation for the emergency. But you've also got the same with electives. So they're also cancelling data on cancelled elective surgery. They're also cancelling data on community mental health activity. And they're also ceasing to collect data on venous thromboembolisms as well. Now, all of that data is, it's not COVID. All that data is quite easily retrieved. It's not that difficult. And they're saying it's because of resources. Sorry, but I suspect it's something else. The other thing they stopped collecting was some ambulance data at the beginning of this. And they stopped collecting eating disorder information as well, which is very interesting because there is apparently being a big peak in patients with eating disorders as well.
Yeah.
So,
thank you very, very much for spending all this time with us and sharing the tips that you have for everything that you said about the children. Obviously, that applies to everyone. Get as much sunlight as possible. Perhaps take some supplements. Certainly, I know in the NHS they have in recent years actually advised us from sort of spring, October time onwards to take those extra supplements. So thank you very much for giving us those tips. Thank you very much for all of the research that you've done and that you've been sharing with us today. And as much as obviously a lot of that information is worrying, I'm hoping that when people actually watch this, it will inspire them to start perhaps looking at things themselves a little bit more deeply and starting perhaps even to talk to their own doctors, maybe to talk to their own MPs, and get the information out about what their concerns are and why. So thank you for doing that for us, and hopefully we'll keep in touch, and if you come up with anything else that's newsworthy and we need to share with people, then we can do that.
And I just think to finish up, sorry about me coughing earlier, is just to say to people that the information is out there if you want to go and look for it yourself. And, all of this isn't people creating crazy conspiracy theories. This is just people trying to understand the truth. And we are at an absolute crossroads, I think, now. And we are in a unique position in history that we have information at our fingertips. We have a lot of misinformation as well, but we have a lot of information at our fingertips. And I always think that just keep asking questions. Ask every question you ask, answer it with another question, and just keep asking yourself the same questions. And don't always understand that what's coming from government and media level is in our best interests, because there are always alternative, reasons for those things. Yeah. So do your own research and ask and start talking to people. Like, people, I think, have forgotten to talk to people, and it's hard when you've got masks on. But if you're in the post office queue, someone's behind you, speak to them and ask them about what they think. Or if you're on the bus, speak to them and ask them what they think. Because I think people will be surprised at how many people are asking questions now and give an opposite view of what we're being driven by the media. So yeah. I'm not saying all media is bad. I'm just saying that do your own research and use discernment and answer questions with questions. I think it's very important.
Brilliant. Right, thank you, Jennie.
Sorry about my comments.
That's all right. That's all right. Thank you very much, Jennie.
Thank you for watching. Remember to visit keepbritainfree.com, like, subscribe and leave your comments below. Join the forums, have your say and get involved.